Today we will be talking on lymphoma. What is lymphoma? As the name implies, it is tumor of lymphatic structures. So first of all, you have to know what are lymphatic structures in our human body. So one is lymph node, another is waldeyer's ring, another is peyers patches in intestine, another is a spleen, another is appendix and thymus. And there are various lymph nodes in our body like cervical lymph node, mediastinal lymph node, axillary lymph node, inguinal lymph node. So when there is proliferation of the B cells and T cells in these lymphatic structures, we call it lymphoma. And in this picture you can see this is the basic structure of lymph node. Histopathologically, they have divided lymphoma into two types. One is Hodgkin lymphoma and another is non-Hodgkin lymphoma. They saw red sternberg cells, typical RS cells which has CD30 positivity. So they called it Hodgkin lymphoma. And other lymphoma they grouped into non-Hodgkin lymphoma. And further, non-Hodgkin lymphoma has been classified into follicular lymphoma, diffuse large B-cell lymphoma, mantle cell lymphoma and many others. But basically we need to remember DLBCL, diffuse large B-cell lymphoma and follicular lymphoma, because these are common non-Hodgkin lymphoma. And depending upon the severity, they divided into high grade lymphoma and low grade lymphoma. They divided this into high grade and low grade for the treatment purpose. I will be discussing that later in the treatment part. Now let's come towards the clinical features. So what may be the picture of the patient? So patient may present with lymphadenopathy like cervical lymphadenopathy, or when you do X-ray you can see mediastinal lymphadenopathy. Patient may have cough due to compression of the trachea, bronchi, or patient may present with a spread to other body parts like brain, bone, skin, but this is rare. And patient may have constitutional symptoms like night sweats, drenching night sweats, fever, weight loss. Unintentionally they may have lost about more than 10% in 6 months. And in non-Hodgkin lymphoma especially you can see compression syndromes like there can be gut obstruction due to myeloma. Due to mediastinal lymph node, it can compress superior vena cava and can cause superior vena cava syndrome, can cause a spinal cord compression. And one characteristic feature that differentiates Hodgkin from non-Hodgkin lymphoma is the spread of lymph node involvement. For example, in a Hodgkin lymphoma, if there is one lymph node involvement here, so it will next will be contiguous involvement, next will be contiguous involvement. So it goes contiguously, it does not skips. But non-Hodgkin lymphoma skips. There can be cervical lymph node, there can be mediastinal lymph node, then it can be inguinal lymph node. So it skips, it spreads haphazardly. For staging, initially Ann Arbor classification was used, but later Ostwald modified this, and now we call Lugano classification or Lugano staging of lymphoma. For Hodgkin and non-Hodgkin lymphoma we use this same staging system. So basically stage 1 is if there is lymph node involvement in one region like cervical lymph node region or mediastinal lymph node region or axillary lymph node region. One lymph node region should be, not one lymph node, one lymph node region should be. Okay, here can be 5 lymph node, but it is cervical lymph node. Okay, and stage 2 is there can be lymph node involvement but on same side of diaphragm. For example, let's say a patient has cervical lymph node, a mediastinal lymph node, axillary lymph node, but these are all on the same side of diaphragm, above diaphragm. So this is a stage 2. But if it is involving both sides of diaphragm, like even there is inguinal lymph node, abdominal lymphadenopathy, so this is a stage 3. And if it has a spread to liver, bone marrow, then we call a stage 4. If you see a stage 1A or 2A, we call it low grade. We treat it differently. We give radiotherapy as well to this low grade. But if there is 1B, 2B, 3 or 4, we call it high grade. We don't give radiotherapy in high grade. We just give 4 to 6 cycles of chemotherapy. I will be talking again this treatment part in the treatment section. Now let's come towards investigation part. So what investigations do we need to do? So first of all, the basic investigations like complete blood count, where you can see anemia, lymphopenia, eosinophilia, neutrophilia, thrombocytosis, and there can be raised ESR, LDH, which are bad prognostic markers. There can be renal derangement as well, and also we have to start some chemotherapy that can be renotoxic. So we have to assess the baseline renal function test, and due to porta hepatis compression due to lymph node, then can be cholestasis like picture. So liver derangement as well can be. So here you can see the chest X-ray, and in this chest X-ray, what do you see? I can see the tracheal deviation towards right side, and there is opacity in the left apical region. There is apical region, you can see the mediastinal region. There is mediastinal lymphadenopathy that is pushing the trachea towards right side. So chest X-ray is also one of the investigation. Next is CT PET scan. So this is PET scan, positron emission tomography. They give fluorodeoxyglucose and they light up where there is highly active or metabolically active lymphoid cells, B cells, T cells. So here you can see the lightening of the fluorodeoxyglucose in the mediastinal region. And another is bone marrow biopsy. So for checking spread to lymph node, from lymph node to bone marrow, we do bone marrow biopsy because this is prognostic marker. We don't do for diagnostic purpose, but it is prognostic. And for confirming whether B cells, T cells, we can do immunotyping. For translocations, we do cytogenetics. And in non-Hodgkin lymphoma, there can be hypogammaglobulinemia. So we also estimate immunoglobulin levels in the serum, and adjunctive tests like uric acid and serology for hepatitis B, C, HIV, because you know that non-Hodgkin lymphoma can occur with these infections as well, hepatitis B, C and HIV. And definitive diagnosis you can do with lymph node biopsy. In this picture you can see the biopsy needle is inserted posteriorly. So this is doing biopsy of the retroperitoneal lymph node. So we discussed what are the different clinical features, what investigations do we do in lymphoma. Now let's come to treatment part. So treatment is different for both Hodgkin lymphoma and non-Hodgkin lymphoma, and it also differs whether patient is has low grade lymphoma or high grade lymphoma. So basically, what do you remember? What are the treatment modalities? One is chemotherapy, cytotoxic chemotherapy, another is targeted therapy, another is radiotherapy, and another is hematopoietic stem cell transplant. And in refractory cases, in relapse cases, we do transplant and CAR T cell therapy. These are last options, but basically you have to remember chemotherapy, targeted therapy and radiotherapy. And ABVD BIA-COP regimen in Hodgkin lymphoma, while CHOP regimen, R-CHOP regimen in non-Hodgkin lymphoma. Now let's talk about Hodgkin lymphoma. So this is divided into whether it is patient has early stage Hodgkin lymphoma or advanced stage Hodgkin lymphoma. For early stage Hodgkin lymphoma, we give 2 cycles of ABVD regimen. ABVD stands for A for adriamycin, that is doxorubicin, B for bleomycin, V for vincristine, and D for dexamethasone. So adriamycin, bleomycin, vincristine, dexamethasone. So we give 2 cycles and combined with involved site radiotherapy. Involved site radiotherapy, which is abbreviated as ISRT. And we then do fluorodeoxyglucose PET scan after 2 to 4 cycles of ABVD, where I have written 2 cycles, but you can go up to 4 cycles depending upon additional risk factors. And after that we do fluorodeoxyglucose PET CT scan to look for metabolically activity or whether there has been remission or not. So this is for early stage. And for advanced stage, we don't give radiotherapy. Initially I told you that we give ISRT in early stage, but here we don't give radiotherapy. Here we go for 2 cycles of ABVD, then do fluorodeoxyglucose PET scan, and if you see there is no remission, then we can change to Biakov regimen for 6 cycles. But if there is remission after 2 cycles, then we can continue the ABBD regimen for 4 to 6 cycles. So I already told you the full form of ABBD. Now let's talk about Biakov regimen. What is the full form of Biakov? B stands for bleomycin, that is the same in ABBD regimen, and E stands for etoposide. A stands for adriamycin, that is also same in ABBD regimen. C stands for cyclophosphamide. O stands for oncovin or vincristine, that is the same in ABBD regimen. And P stands for procarbazine, and last P stands for prednisolone. So bleomycin is same, adriamycin is same, oncovin or vincristine is same, and steroid is same. So ABBD, all those ABBD are included in Biakov regimen basically, but extra are etoposide, extra is cyclophosphamide and procarbazine. 3 extra and 4 the same drug above ABBD. Just the letters are different to make it sound Biakov, so that it sounds like Biakov. If you arrange these letters otherwise it may not sound good, so they have substituted the letters. Like in the ABBD they have used vincristine V, but here O for oncovin or vincristine. So if there is no response with ABBD, then we change to Biakov regimen. Biakov regimen is widely used in UK, but they have lot of toxicity because bleomycin causes pulmonary fibrosis. So due to those side effects, we generally don't prefer Biakov in our setup. We initially go with ABBD regimen. But if there is no remission, then what we can do? We have to change to Biakov regimen. And if there is a relapse of Hodgkin lymphoma, then we have to go for autologous hematopoietic stem cell transplant. And I talked about immunophenotyping in the investigation section, and red Sternberg cells have CD30 on its surface. So monoclonal antibody against that CD30 is brentuximab. So you can also use brentuximab in advanced stages. And RS cell, these red Sternberg cells also express PD ligand 1. So PD ligand 1 is, you can imagine like ID card, like when you go for a security post, security checks you. If you have ID card, then he thinks that, oh, he is fair or he is good, you can let him go. But if there is no ID card, his security guard won't identify and he blocks you. So similarly, PD ligand 1 is ID card for a cell, that this is a good cell, this can go for, you don't interrupt this cell, this is a good cell or healthy cell. So these RS cells overexpress PD ligand 1, they make fake ID card, so that the security guard or the T cells that have PD1, that have the scanner, PD1 I call it a scanner that scans the ID card. So T cells has PD program death, so it scans that there is ID card PD11 present, so don't kill it, let him go, he is a healthy cell. So these red Sternberg cells makes fake ID card, and it escapes the T cells scanner and go on proliferating. So what we do, we stop the interaction of this PD and PD ligand so that T cell can kill it. So that is the concept of immune checkpoint inhibitors, and the drugs are pembrolizumab, nivolumab, and many other drugs are widely used nowadays in immunocheckpoint inhibitors. But you have to remember pembrolizumab, nivolumab for the Hodgkin lymphoma. Now talking about non-Hodgkin lymphoma, this treatment again is based on whether it is low grade or high grade non-Hodgkin lymphoma. Follicular lymphoma, if you see, they have indolent course, relapsing, waxing, waning course, and even if you don't treat this follicular lymphoma, patient can have median survival like 10 years, 12 years. So we call it low grade non-Hodgkin lymphoma. If there is asymptomatic, then even we don't need to treat those cases. And for high grade non-Hodgkin lymphoma like diffuse large B-cell lymphoma, we have to start the chemotherapy regimen. So what is the treatment of non-Hodgkin lymphoma? So R-CHOP, ABBD in Hodgkin lymphoma, R-CHOP in the non-Hodgkin lymphoma. and R-CHOP stands for R for rituximab, which is anti-CD20 monoclonal antibody, and C for cyclophosphamide, H here, H for adriamycin, that is doxorubicin, O for oncovin or vincristine, P for prednisolone. So here you saw there we had written A for adriamycin, here H for adriamycin, doxorubicin. It is basically it is same thing. Somewhere we write V for vincristine, somewhere we write O for vincristine. And if a patient has low ejection fraction or cardiac compromise, then we eliminate H, because we know that doxorubicin has irreversible heart effect on a heart. So we eliminate H and we give only RCBP. And other is R-bendamustine. Bendamustine is alkylating agent. So combining alkylating agent with anti-CD20 and monoclonal antibody rituximab, this has also been shown to be good result in randomized control trial. So we can give 6 cycles of R-CHOP regimen. And if there is compromise of cardiac function, then we can eliminate H, or we can switch H to gemcitabine. So R, C, G, VP. C is for cyclophosphamide, G for gemcitabine, V for vincristine, and P for prednisolone. And this is chemotherapy. Now targeted therapy. So what is targeted therapy? This targeted therapy targets certain enzymes, like these B cells, there is B cell receptor, and when there is B cell receptor engagement, what occurs? That signaling occurs, cell signaling, that is mediated through PI3 kinase and Bruton tyrosine kinase. So we inhibit this PI3 kinase inhibitor with idelalisib and Bruton tyrosine kinase inhibitor, Bruton tyrosine kinase with ibrutinib. So when you inhibit it, the cell proliferation through BCR signaling pathway stops and the cell dies. So this is the targeted therapy that is widely used in non-Hodgkin lymphoma. And ISRT, which stands for involved site radiotherapy, we give if patient has a stage 1 without bulky disease or residual localized site of bulk disease. Even there is bulk disease and it is localized, then we can give involved site radiotherapy. And obviously for compression syndromes like a spinal cord compression, we can give radiotherapy. And last is hematopoietic stem cell transplant, we give in relapse cases, refractory cases. So we discuss treatment overview. So the take home message, if you want to take anything from regarding treatment, ABBD for Hodgkin lymphoma and R-CHOP for non-Hodgkin lymphoma. ABBD for Hodgkin lymphoma, R-CHOP for non-Hodgkin lymphoma. Now let's talk about prognosis of Hodgkin lymphoma and non-Hodgkin lymphoma. Regarding Hodgkin lymphoma, if you see the early stage Hodgkin lymphoma, 90% achieve complete remission. 90%, fairly good. You can imagine it. 90% achieve complete remission. And regarding advanced stage Hodgkin lymphoma, about 60% of advanced Hodgkin lymphoma are cured. So you can see the progress of this science, oncology. And regarding advanced Hodgkin lymphoma, we do prognostic staging with Hazen-Kleber prognostic index. Like in non-Hodgkin lymphoma, we will discuss later, international prognostic index we use. Here we use Hazen-Kleber prognostic index, which is based on age, male gender, albumin level, hemoglobin, stage, advanced stage disease, WBC count greater than 15,000 and lymphocytes less than 600. Now let's talk about prognosis of non-Hodgkin lymphoma. I already told you that for low grade non-Hodgkin lymphoma like follicular lymphoma, survival is fairly good enough. Like median survival is 12 years, you can imagine. And for high grade, we do prognostic staging. And on what parameters this prognostic index is based? International prognostic index. One is age, another is whether it is early stage or advanced stage, or whether patient has any concomitant disease, and level of LDH. So if there is increased age, advanced stage, concomitant disease or raised LDH, then 5-year survival is 20%. But if these are not there and patient is low risk score, then 5-year survival is greater than 70%. So this is in nutshell about lymphoma. We discussed about Hodgkin lymphoma, non-Hodgkin lymphoma, what are their clinical features, and what investigations do we do, and what are their treatment modalities, from chemo, targeted therapy, radiotherapy, hematopoietic stem cell transplant, CAR T cell therapy, and prognosis. So we discussed that Hodgkin lymphoma has fairly good prognosis, and nowadays we are just focusing on minimizing the toxicity in Hodgkin lymphoma treatment rather than increasing the lifespan, because we saw it has very good prognosis, and we generally eliminate or don't give radiotherapy in Hodgkin lymphoma if patient has PET-CT responsiveness after 2 to 4 cycles of ABCD. Because why do you need to avoid radiotherapy? Because patient has increased chance of development of later cancer. Like if you radiate female, there is increased chance of breast cancer, and other cancers is increased, so skin cancer. So we have to do surveillance of those cancers. So if there is a fairly good response with chemotherapy, then why do we add extra radiotherapy? Yes, so scientists are thinking in this way. So this is in our view of lymphoma. I hope it helps. Thank you. If you have any questions and concerns, you can comment it down, and I will be always happy to answer it. Thank you.